Now, as we go through this presentation, we're going to be talking in terms of certain building blocks that are in the Affordable Care Act. It expands access to coverage. The Affordable Care Act increases consumer protections. It emphasizes prevention and wellness. It improves quality and outcomes of care. And finally, the ACA will lower health care costs. So let's just talk a little bit about the Medicaid expansion, the way that access is expanded to health care. The first of that is through Medicaid. And under the Affordable Care Act, all adults up to 138% of the federal poverty level are eligible for Medicaid. Now, the problem is that it's become sort of optional for the states. After the Supreme Court's decision this past June, the penalty, which really forced the states to do the expansion, the penalty which really forced the states to do the expansion was taken away. And for that reason, we are now seeing that in Ohio, we're actually thinking about should we do this, should we undertake this or not. And in Ohio, right now, there is we're waiting until perhaps through the budget process, which could come as early as the end of November or as late as February, to know whether or not the state will adopt the Affordable Care Act Medicaid expansion. And we also know that just recently the Kasich administration has requested the federal government for permission to reduce the Medicaid expansion to 100% of the federal poverty level. And that is basically a big issue because there are a lot of folks between 100 and 138% of poverty who will really need to get their health care without having to pay any kind of cost sharing. So the federal government thus far has held very firm in saying that the expansion has to go to 138% of the poverty level. We hope that, in fact, the federal government will continue to hold firm on that. With respect to the other way that people will get coverage is by having their coverage through the exchange. There will be a choice of private insurance plans with financial help available to those who qualify, and we'll talk a little bit more about that as we move on. Just so you know, we'll be talking about certain levels of federal poverty level where people can get assistance. And so we talked about 100% and 138%, and you can see that the difference there is really considerable. Looking just at a family of three, the difference between $19,000 or $26,000 a year in income, determining whether they're going to be able to get Medicaid or not. Let's talk a little bit about the exchange. This is the insurance marketplace which will become available in 2014. The exchange will create a one-stop shop for easy comparison of coverage options. What this means is that people can sit in front of a computer screen and see three plans all put up at the same time, comparing across benefits, premiums, cost sharing, etc. This is something that we don't have right now, and it will not only do that, but will help people pull up those plans based on a number of factors, such as the provider that they are most interested in having covered. The exchange will give consumers more choice and more control. It gives them more choice because they will actually, and think of this particularly for those consumers who are employees of small employers who go into the small business exchange called the shop exchange. Employees in the same company will actually be able to choose plans from different insurers, and yet the employer will just get one bill. There will be subsidies for individuals in the exchange, and these will be called advanced tax credits. People will have help from navigators to figure out what their tax subsidy will be, and then they will be able to actually make a choice based on what they can afford. The tax subsidy will be paid to the insurance company by the federal government through the tax system, and the individual share of premium will be sent by that person to the company, all in one easy transaction. And this will make coverage more available for individuals and for small businesses. The interesting thing about the exchange is that Congress will get its coverage through the exchange, Congress and its staff. And we have found that many people are very enthusiastic about that because we know that if this isn't working right, Congress will have the incentive to fix it. Now, let me just talk a little bit about these premium credits. We have what's called the metal levels of these plans. There's platinum, gold, silver, and bronze. And the premium credits apply to silver plans. Silver plans are the second least costly plans. If people's income falls within the ranges that you see on this slide, they will be paying that percentage of, a maximum of that percentage of their income for their premium. So for example, if someone's income is between 200 and 250% of the poverty level, they will pay a maximum of 6.3 to 8.05% of their income for their premium credit. For their for their share of premium. The cost sharing works a little bit differently. The way that the government is calculating people's share of costs is through something called actuarial value. And that simply means that it's the percentage on average that a population would pay for their cost sharing. So for example, between 200 and 250% of poverty, on average, people will pay 73% of their costs. But that's only on average. Some people will pay less than that. Some people might pay more. But the important thing is that there's a cap, so no one will pay over a certain amount. For the values that were in effect in 2010, that would be $2,000 for an individual and $4,000 for a family. These will shift a little bit each year based on cost of living changes. And you can see here, just by way of reference, what the various poverty level incomes are. So going up to 400% of poverty for a family of one, $44,680, and so forth. And these slides will be sent to you at a later point, so you can reflect on these various levels when you have more time. I want to talk a little bit about navigators. And the navigators are those folks who will help people to use the exchange. They'll inform them about their new insurance options. They'll help people enroll in their plans, and they will help people keep the coverage that they've gotten. Many people won't have access to a computer, and that's why it's important that we have navigators who can sit down with people in public places where there are computers, perhaps enrollment fairs, and help them pull up the plans that will help them and help them get the information that they need so the individual can make his or her own decision about which plan is best for him. Navigators will be trusted community members, and they could also be insurance brokers or agents. We want to make sure that people in communities, in rural communities, where there is not good access to telecommunications or internet, that people who don't speak English as their first language, that people in communities of color where many people may not have had health coverage in the past, will all have access to people they can trust, these navigators, who will help them choose a plan. The navigator does not himself choose the plan. The navigator does not even advise on which plan to choose, but provides information to the individual. And what's important is the navigators cannot receive direct or indirect payments from health insurers. And that's important to make sure that we don't have any conflicts of interest influencing the selection of a plan. Now, many people are concerned about the individual responsibility requirement. We find in communities where we go and where people have not been insured, they actually have a lot of fear around the Affordable Care Act because of the mandate. What we want everyone to understand is, first of all, there are very few people who will actually be caught by the mandate without having the subsidy that they need to make coverage affordable. people can get coverage either through their employer, through Medicaid, through Medicare, through the TRICARE program, which serves the military, and the subsidies in the exchange. But you need to know that many people are exempt from the mandate, and we list a number of them here. And most importantly, I want to point out that there are folks who have the whose income is so low that they are not even required to file a tax return. They are not caught by the mandate. Individuals where the lowest cost health plan available would exceed 8% of their income, they are not caught by the mandate. So why is this mandate necessary? We sometimes hear people say that they would keep the Affordable Care Act's pre-existing condition protections, but they would get rid of the mandate. Well, it all kind of fits together just like a three-legged stool. The guaranteed issue requirement that insurance companies have to cover people regardless of a pre-existing condition, you can't have that unless you have a lot of folks getting into the insurance pool and not waiting until they get sick to do it. And you can't have everyone getting into the insurance pool unless you have a subsidy to make it affordable. And that's why this three-legged stool has been drawn up as a good metaphor for what's needed to make sure that the Affordable Care Act can work. Now, what about in Ohio? Well, so far we're hearing that we will have a federal exchange in Ohio, or that the governor at least is leaning toward a federally facilitated exchange. But we really don't know that. We do know it's a bit late for the state in the first year at least to do its own state-based exchange because there has not been the necessary preparation. But even as late as November 16th, when the decision has to be communicated to HHS, we could have a partnership exchange in Ohio. And we're just going to have to wait and see what happens. We know there's a lot of discussions going on at various levels, including in the legislature, about what would be best for Ohio, and there's a strong desire that Ohio not give away any of its flexibility. Right now, advocates are working to make sure that the exchange and the Navigator program will work for all Ohioans. We want to see a Navigator program that has sufficient funding, whether that's coming from the federal government or from the state of Ohio through a partnership exchange. And we are working right now to assess who's interested in doing in being a navigator, what organizations might be thinking about applying for this, so that we can make sure in advance of October 1st, 2013, when open enrollment begins, that Ohio will have a good, strong, working navigator program. I'm now going to turn this over to Kathy Levine, UHCAN Ohio's Executive Director, to take it from here. Kathy?
Thank you, Kathleen. The coverage provisions that Kathleen reviewed are the most well-known, but I'm going to review other provisions. First, the Affordable Care Act increases consumer protections. It ends discrimination based on pre-existing conditions, but also discrimination based on gender. Young adults can stay on their parents' policy until age 26. The law prohibits lifetime and annual dollar caps on benefits and prohibits insurance companies from canceling policies except for non-payment or fraud. Next. The law also has a lot of provisions to improve the quality of care and improve health outcomes as well as lower costs. There's a big emphasis on prevention and wellness. For instance, the law eliminates copays and deductibles for preventative care. It expands funding for community health centers, which provide ongoing primary care in medically underserved communities. It creates a prevention and public health fund to expand prevention and public health programs, and requires chain restaurants to disclose the nutritional content of the food they sell. The law also requires hospitals to do community needs assessments and develop community benefit plans to address how hospitals are going to help address unmet community health needs. It provides funding to increase workforce development activities. It reduces payments to hospitals that have more than expected amounts of preventable complications and readmissions. This is important because right now, one of the problems in our healthcare system is that we pay for volume of care instead of value of care. And hospitals that have higher than expected bad harm to patients will get paid by lower reimbursement rates. It also requires collection of data on race and ethnicity. If you don't measure something, you can't fix it. Next. I want to talk a minute about reducing health disparities. Health disparities are the differences in rates of disease, health outcomes, and access to health care found between different groups of people. And they are important to fix because it improves the health outcomes of the communities that are affected, but it also improves the health status of our whole population. So how does the Affordable Care Act address health disparities? Well, there's a great potential to add resources to medically underserved communities with high incidence of health disparities. For instance, the law has expands funding for community health workers who do person-to-person, high-touch outreach to people who need to connect with health care. It expands community health centers, the expansion of Medicaid, the expansion of new models of care, which we'll talk about, the Navigator program that Kathleen talked about, and the funding for prevention will all help to reduce health disparities, combined with measuring and targeting improvements in communities that need it. Now, the law also does more than most people realize about starting to lower healthcare costs. We have a very expensive healthcare system, the most expensive system in the world, and we're not getting good value for what we're paying for. One of the ways that we can make the system work for everybody and provide coverage for everybody is to get a handle on healthcare costs. So there are many ways in which the law lowers healthcare costs. Focusing on prevention, primary care, and public health will cut down on treatment of expensive diseases that could be prevented early on. The law does a lot to develop systems for better coordination of care for people with chronic conditions who see multiple doctors in multiple settings. It incentivizes hospitals to reduce preventable harm, which costs a lot to pay for, and any proposed premium increase of 10% or more, an increase to your premium of 10% or more, will be evaluated by experts to determine if those premium increases are necessary. So what's happening in Ohio now about costs to attack the double problem of high cost and low quality of care? There's a lot of focused work on coordinating care through the use of patient-centered medical homes. There is attention on developing a system to better serve individuals who qualify for both Medicaid and Medicare. These are patients who have significant problems, both health and they have high health needs, and also the need for long-term care services. And so they're very costly. And we're moving toward paying for value, not volume. So just to give you an example of the problem, this is a slide from Governor Kasich's Office of Health Transformation, which is leading the effort in Ohio to figure out how to move toward the triple aim of better health care, better health outcomes, and lower costs. The problem is Ohioans spend more per person on health care than residents of all but 13 states. Rising health care costs are eroding paychecks and profitability. Higher spending is not resulting in higher quality or better outcomes for Ohio citizens. 41 states have a healthier workforce than Ohio, so there's plenty of room for improvement. This slide, which you'll receive later, shows that Ohio's healthcare system performance is overall ranked 42nd among 50 states. And so we have a lot of measures in which we're in the 4th quartile of all the states. Again, a lot of room for improvement to improve health care, improve health outcomes, and lower costs. Next. So what Ohio is doing is developing new models of care. No one in the country has a silver bullet for improving quality and reducing costs. A lot of models have proven to be very helpful at improving quality and reducing costs on a small scale. What we're trying to do now is to figure out how to expand these models to serve most of the population so that all of us have access to this better kind of health care, particularly people with multiple chronic conditions, older adults, people with disabilities, vulnerable populations, people with low incomes. So the promise is to provide better care coordination. A lot of health care today is fragmented. Doctors don't talk to each other. They don't talk to the patient. And so that people get less wasteful care and get the right care at the right time and place. We're promoting health homes, and the ACA created this health home opportunity, which gives federal money with a 10%, just a 10% state match to provide care for Medicaid enrollees who have serious and persistent behavioral health conditions. They get both their physical care and their behavioral health care in one setting. And these are folks who are at great risk. They tend to die 25 years earlier than other people from untreated physical conditions. And they end up costing the system a lot of money. So the patient, all of these models have in common the notion of a patient-centered medical home, which just meets primary, which is basically primary care on steroids. It's robust primary care where the patient is at the center, where people are treated as a whole person. People get the resources they need to improve their own health, and the program links people with both health, medical and non-medical resources to improve your health. And it also includes figuring out how to pay for value of health care, not volume. There's also provisions. There's a provision to expand in the Medicaid program to increase the reimbursement rate for primary care doctors and other primary care providers in Medicaid. That will go into effect in January of 2013 and last through 2013 and 2014 to entice more primary care docs into Medicaid. So that's it for me. I'll turn it over back to Kathleen.
Yes. Well, and the ACA saves money in other ways, too. I mean, it creates competition among health plans. I mean, Kathy talked about the ways that the ACA helps to actually reduce costs, but the ACA puts money back in people's pockets by having health plans not have as much of it. Gradually, it will lower prescription costs for Medicare recipients and close the coverage gap, or what we often call the donut hole, by 2020. Within the ACA, we have provisions to fight waste, fraud, and abuse in the current system so that people who are actually stealing our dollars don't get it, and in fact, people keep their dollars in their own pocket. And finally, there's a requirement that insurance companies cannot spend any more than 20% of premium dollars on administrative costs or profits. Sometimes this is referred to as the medical loss ratio, and more commonly people call it the 80-20 rule, but basically 20% of premium dollars only can be spent on administrative costs or profits. Now, we know that there are a lot of myths out there that are getting in the way of people who think that the ACA is doing very bad things, and we're running a little late here, and I know we want to get to your questions, so I'm just going to touch on these. First of all, the ACA is not a government takeover of health care. In fact, it's using the system that we have right now, the private insurance system. It does not cut $716 billion to Medicare beneficiaries, which we often hear. There are savings in the Medicare program. Some of those savings, and those savings are brought about, for instance, by cutting fraud, waste, and abuse, by paying Medicare Advantage plans only what they really should be getting and not the additional subsidies that they were getting in the past. And as a result, Medicare beneficiaries are actually seeing a better benefit, such as getting preventive care without being subject to copays and deductibles, and seeing the donut hole closed. Some of the money, yes, this money is paying for the Affordable Care Act, but it's all coming together to create a health care system which is cost effective. The mandate is not the largest tax on the middle class, despite what has been frequently said. In fact, it's a very moderate tax because there are very few people who will actually be caught by the mandate. And the Affordable Care Act doesn't add trillions to the debt. In fact, when the Affordable Care Act proposed repeal was being analyzed by the Congressional Budget Office, it found that if repealed, there would be about $105 billion added into the debt because of the various cost savings in the Affordable Care Act that would no longer be there. And finally, the Affordable Care Act is not a jobs killer. As we talked about earlier, the small businesses actually have the option of going into the shop exchange and getting affordable coverage for their employees, and in a way that is actually much simpler for them to purchase. And the other thing to note is that no employer with fewer than 50 employees is required under the Affordable Care Act to provide health coverage. So Alyssa, if you've been submitting questions, Alyssa has been looking at them. Kathy has to leave for another meeting before we get to 3 o'clock, so those questions that are mostly aimed at Kathy will be answered first. And Alyssa, do you want to take it back?
Thank you, Kathleen. So we're just asking that everyone, if you have any questions relating to the Medicaid expansion, health disparities, any of the topics that Kathy specifically spoke on, please submit your questions now, and we'll answer those first. If I don't get any of those, then we'll move on to a few of the other topics. So while we're waiting for a question for Kathy, one question that was submitted is it already determined that insurance brokers can function as navigators in Ohio? If so, why would an insurance broker want to be a navigator if he or she cannot get any payment from an insurance company? How do they get paid?
Okay, Alyssa, I'm unmuted?
You are unmuted,
okay.
And Kathy
okay.
is unmuted.
Oh, okay. All right. Thank you. Well, brokers and agents can serve as navigators based on the Affordable Care Act itself and the regulations as put out by HHS. So there's no barrier to them, whether it's in Ohio or any other state, being a navigator. We think in most cases they probably will not choose to be navigators because the way that a broker or an agent makes his living is through the premium, you might say the little slice of a premium or the share of premium that they are paid when they bring a person into an insurance plan. So it's our expectation that most brokers and agents will continue to function as brokers and agents, helping their clients, both small businesses and individual clients, to select plans. There are things brokers and agents can do that navigators cannot do. The brokers and agents can give a full range of advice about what plan to choose, and a navigator will be limited to providing information about the plan so that the person can himself or herself choose the plan. But that individual, the navigator can help that individual right up to the point of enrollment. The individual they can be sitting together at a computer. The individual can then select the plan. and the navigator can help with the functions of the computer if that person isn't able to do that. But we expect that both navigators and brokers will be able to interact in harmony in Ohio.
Okay, great. We have one question quick for Kathy before she takes off. Can you touch more specifically on what exactly person or patient-centered care is?
Sure, that's a question I love. Right now, many of us, particularly people with chronic conditions, go to the doctor and it's hard to get an appointment. If you have a problem, I mean, people normally get sick on Saturday night. I mean, that's just the way our bodies are, work. And, if you wonder whether you need emergency attention or can wait till Monday, you should be able to call somebody at your doctor's office and find out what to do rather than go to the emergency room to get the answer to the question. Patient-centered home has 24-hour care. It's more designed to work with the patient as a partner. Instead of just having a relationship with a doctor, you have a relationship with a team of people. So if you've got several chronic conditions and you need to change the way you eat or increase exercise, there are people who can, in the team who can help you. If you Google patient-centered medical home or you go on our website, there is information about patient-centered medical home, or you can contact me at C. Levine at UHCAN Ohio for more information. This is a new way of building robust primary care that works with patients to improve their health outcomes, and doctors and the team will be paid not based on how many tests or how many times they see you, but they will be paid on improving your health outcomes. A patient-centered medical home has been shown to reduce health disparities, to improve the outcomes of people with diabetes, hypertension, and the other epidemic chronic diseases that are costing us so much money today.
Great. Thanks, Kathy. I actually have another question for you. It's about the integrated care delivery system. And the question is, how can, through the integrated care delivery system, how is it cheaper when it's going to be run by managed care organizations?
Well, that's a great,
contract.
I'm sorry. That's a great unanswered question. For people who don't know what that question refers to, across the country, there's interest in figuring out how to provide better care coordination for people who are on Medicaid and Medicare, because there are two systems that don't work together. And, the Ohio Medicaid, if the Medicare system, if they do a terrible job taking care of people's health care, then people go into nursing homes that's paid by the state. So they've got perverse incentives, to not work together. So there's a lot of interest among policy makers and consumer advocates and providers of care to older adults and people with disabilities to provide better care. Well, in Ohio, we answered a national, call in the Affordable Care Act to improve care for people who are on Medicaid and Medicare by proposing to enroll people in what Ohio is calling integrated care delivery system plans, which are managed care plans. And these managed care plans will get money paid from Medicare, a federal program, and Medicaid to coordinate care across settings. And the question is, if these are Wall Street traded for-profit plans, and at least 3, maybe 4 of the 5 that are going to be operating in Ohio meet that description, how are we going to be saving money? And I think the answer to that question is going to be on public accountability. Are we going to know how much these plans are being paid, how much they're spending on health care and long-term care services, and how much money they're sending to their shareholders? I think we're going to have, consumers are going to have to be very involved, particularly in protecting the quality of care and demanding better care both health care and long-term care services for older adults and people with disabilities, and to make sure there's a consumer voice in these plans, but we also need to know more than we know now about how the money is being spent. So the potential for saving money is that many older adults in particular end up, and people with disabilities to a smaller extent, end up in nursing homes when they could be staying at home because they don't get the high-touch care they need to stay at home, and it's much cheaper for them to stay at home. So if we can improve the care that they get and keep people healthier, we will save a lot of money. The question that the caller raises is, well, who's going to reap those savings? The managed care plan, providers, consumers, taxpayers? Are they going to be invested in better long-term care services for people? So that's a question that we need to answer. Sorry for such a long answer. And with that, I'm sorry, Alyssa?
Who is advocating for seniors in this situation?
Thank you. UHCAN Ohio is building a coalition now, a consumer coalition, along with Ohio Olmsted Task Force and the Ohio Areas on Aging and many other consumer advocates. We're putting together a coalition to protect both seniors and people with disabilities. And if people are interested in this, please get in touch with us and get involved. And with that, I have to leave, but if people have questions for me, email them and I will answer them later, and maybe we'll post them on the website if they're of interest to everybody. I'm going to turn it over now to Kathleen and Alyssa. Thank you.
Thank you. Continuing with our line of questioning, can you explain, Kathleen, if dental and vision services are part of coverage through the exchange, or talk about if they're a part of the essential health benefits package?
Well, the essential health benefits package, and let me, for those who don't know exactly what that is, because we didn't touch on it in this particular presentation, but the essential health benefits package are those sets of benefits that have to be provided by any plan that wants to be a qualified health plan in the exchange, or that essentially has to be provided by all plans if they're not, self-insured plans starting January 1, 2014. And there is not an adult dental benefit in the Affordable Care Act. There is a pediatric oral health benefit, and that is currently being worked on by those groups that are determining exactly what Ohio's plan is going to look like. Ohio missed a deadline of September 30th to select its benchmark plan, the plan that would have the essential health benefits in it for Ohio. And so it kind of remains to be seen at what point the federal government will say, well, we're actually going to now fall back on the federal benchmark, which would be the smallest, the largest of the small business plans in Ohio, which we think is an Anthem PPO plan. In terms of the vision, I have to confess that I am not exactly sure. I do not believe vision as such is in the ACA for adults. It's not something that I've been asked about or really have looked at for sure. So we'll get back to you on that question. Certainly eye exams and all of that is included just as it is in any other kind of major medical plan. But usually with vision, we're talking about eyeglasses, and I feel pretty confident in saying I'm afraid for adults that's not included. For children, it would be included because it's part of what we right now consider the EPSDT, or early periodic diagnosis, screening, and treatment level of benefits that are in Medicaid, and so that that set of benefits needs to be included in the essential health benefits for children.
Can you talk more about how the tax credits and subsidies work? Are they going to be extended to co-pays and deductibles along with subsidies of overall premium costs?
Could you just restate the question, because I'm not sure if I heard it exactly correctly. I want to try to get that right. Just say it again.
Are tax credits or subsidies going to be extended to co-pays and deductibles along with subsidies of overall premium costs?
And basically, only for people whose income is less than 250% of the federal poverty level will there also be support for the cost sharing. Everybody up to 400% of the poverty level can get help with respect to their premiums. And as you know, when you get up to close to 400% of poverty, you're looking at owing more than 9.5% of your income in order to actually see a subsidy. So it really gradually levels out as we get close to that level. But for the cost sharing subsidies, you have to actually be under 250%. And then, and I'm not sure if, I think I can move these slides. Oops, that takes me forward. I want to go back. See if I can get back to the slide that we
Go to slide.
Oh, go to slide. Okay. If you look at the cost sharing there, you'll see that between 100 and 150% of the poverty level, when the subsidies are figured in, it's estimated that people are getting an actuarial value of 94%, which would be cost sharing of about 6%. Now, that doesn't mean that every person is paying 6%. It means that the population is paying 6%. Some people will be paying more, some will pay less. But then there also will be the cap, the overall cap, which keeps that cost sharing from going above an amount that's roughly $2,000 for an individual and $4,000 for a family at that low level. I hope that at least partially answers the question that the person had.
Okay, another question we have is, does the ACA do away with Medicare Advantage plans?
The answer to that is no. The ACA does not do away with Medicare Advantage plans. What the ACA does, it says that Medicare Advantage plans will no longer be paid 14% more than traditional or original Medicare is being paid. In other words, if you just to give you a little history, the Advantage plans got started some number of years ago, 12, 14, 15 years ago, and at that time they said, you know, we think we can actually provide a services for a set of Medicare beneficiaries more cheaply than original Medicare can do it. And so the federal government set up a payment system for Advantage plans, but over time it has turned out that original Medicare is 14% less costly than the Advantage plans, which wasn't at all the way it was supposed to work out. And so under the Affordable Care Act, the Advantage plans are no longer automatically paid the amount they were paid. Now, they do have the opportunity to earn a bonus, and that's based on quality outcomes. And so plans that are providing demonstrable outcomes showing higher quality will be able to get bonus payments. Now, what does an Advantage plan decide to do when it is not getting paid as much as it was before? Well, one thing it could do is work harder to produce higher quality to get the money that that extra money through a bonus, and we think that's probably what most Advantage plans will do. But perhaps some Advantage plans will say, you know, without that extra money, we don't want to do this anymore, or maybe it will change how it does it. So there's things that those plans will be making decisions around, but the Affordable Care Act does not get rid of Medicare Advantage plans.
Okay. Do you have any idea how much it would cost per employee per month for a small business employer to cover their employees?
It's really not possible to say how much per employee per month because of a lot of reasons. One, as we talked about earlier, there are the different metals. You know, there's the platinum, the gold, the silver, and the bronze plan. So it certainly depends on what the employer is choosing for his employees. I mean, the employer can essentially say in the shop, my employees can make any selection they want from the bronze plans or from the silver plans or whatever, and I will pay X amount of dollars toward their premium, or I will pay X% toward their premium. And so there's a lot of factors involved, which is which level they choose. It's going to depend on where they live, which region they're in, because region does influence cost to some extent. And it's going to depend on what the market is doing at that point. It's going to depend on how many people go into the exchange. The hope is that the exchange will be very full. I mean, lots of employers will go into it, creating a very large pool, and that premium prices will be spread out further. If that's not what happens, and we have a smaller pool, then that's going to influence premium prices. So right now, it's really not possible to say X is how much a small business can expect to pay in the exchange. Now, over the next year, a lot of this is going to become more clear because the plans, will be, the health insurance companies will be putting together qualified health plans that they will then submit. Either if we have a state partnership exchange, they will submit to the state, and if we have a federally facilitated exchange, they will submit to the federal government to be approved. And then as they begin to market those plans, we will be able to see what the price is, in different parts of the state at different plan levels.
Okay. Can you touch on again more about navigators? You stated that they're trusted community members, but can you state who they are and where they come from and who pays their salary?
Well, I'm really glad that someone asked that question. First of all, there's a lot we don't know about navigators yet, and again, that comes down to the fact that we are not entirely clear in Ohio whether we will have a state-based exchange or a federal exchange. And if it's a state partnership exchange, whether the state will choose to run the navigator program or leave that to the federal government. The money to pay the navigators, if it's a federally facilitated exchange, will come out of the federal budget, and most likely there will be requests for proposals that will be issued by HHS sometime next year, 2013, after the budget is resolved. And you may know that the budget was postponed this past fall with a continuing resolution that keeps our old budget, our old 2012-2013 budget, or I should just say our 2012 budget, in place, not just up until October 1st of 2012, but all the way up until the end of February of 2013. But when that money begins to flow, requests for proposals will go out, and then we presume fairly large organizations will apply to be navigators. And we say rather large because there is a certain amount of capacity that's required to be able to administer a large federal grant. We then expect and hope that the larger navigator organization will subcontract with organizations that serve particular communities in our state, and that's where the trusted member of their community comes. We are hopeful that those navigator organizations will recognize that there are organizations all over this state who are serving people, whether it's in Appalachia, whether it's in the inner city of Cleveland or Columbus, whether it's serving persons with AIDS, serving persons with mental illness, persons with substance use disorder, people with other specific diseases, people who live in very rural areas, that they have the capacity to get to those people, and that it would be very much more cost effective for that navigator organization to contract with smaller groups that really do meet the needs of those communities.
Okay, a follow-up on navigators. How and where would a patient find a navigator, and when and where will navigators be trained?
Again, these are some questions that we don't totally know the answers to. Navigators, once they have a contract whether it's with the federal government or with the state, or whether it's a subcontract, of a smaller group to a major navigator, they will be tasked to go into the communities where people can be found, to do the outreach, not to simply put up a shingle somewhere and say, come here, but rather to go out and find the people who really need their assistance. What was the other part of the question, Alyssa?
How will they be trained?
How will they be trained? The National Association of Insurance Commissioners has recently put out a white paper that talks about some of the key components of navigator training that need to be there, but it will be up to, again, whoever's navigator program Ohio is benefiting from, either the state or the federal government, to design the training. They will have to be navigators will have to be trained in how to understand a qualified health plan, how to assist someone to go onto the computer and make the comparisons, how to calculate the subsidy, how to determine whether someone is eligible for Medicaid rather than needing to go into the exchange to purchase insurance, how to advise people on the different things that could happen. For example, we want, when people go into the exchange and have a subsidy, they need to know that they have to report during the course of the year any changes that might occur in their income, because their subsidy will be based on their income, and if their income should rise, it could cause the subsidy to be reduced. And if they don't report that change, at the end of the year, the person might find out that he or she owes some money back to the federal government because they got a subsidy that was greater than they were entitled to. And so the navigators need to be trained so that they can let people know that these are things that they have responsibilities to do, so that folks are not, met with any surprises at the end of the tax year. There's a lot that will be involved in training navigators, and navigators will have to be folks who are very, not just well-trained, but intelligent people who can be counted on by the people to whom they're giving information to give them correct information. Navigator organizations will have to have systems in place to make sure that the people working for them are continually getting updated in information that they may need to know. And one of the issues I think we're going to see develop more as these discussions go on in Ohio is to what extent the Department of Insurance has control over the navigators and has, let's say, review power over what they're doing, or has any way of reining in any navigators who might be passing out, information that's not correct. I mean, we consumers have a kind of dual role here. On the one hand, we want to make sure that the net is cast wide, and so that many people could become navigators, or navigator with another term which is being called assisters, people who can be out there assisting in the community, because we want to make sure that there's folks that are in the Somali community, and the Russian-speaking community, and the various Asian-speaking communities, et cetera. And at the same time, we want to make sure that all the folks who are, who may be a very unique group to be able to reach out to those communities are also well-trained so that they are all getting correct information. And that may best be done by some division of labor, where some people, will reach out and find people who need to get to the exchange, and then perhaps bring them into a situation, whether it's some kind of an enrollment evening, an enrollment fair, if you will, where there will be people there who can answer the harder questions. So I would not be surprised at all if we don't see within navigator organizations some distinction of responsibilities to make sure that we cover the dual aim of getting out to the widest group of people, and at the same time being able to make sure that everybody is getting the most accurate information. I'm realizing, Alyssa, it looks like we have now gone 3 minutes over our limit, and I just want to go to the last slide here on the what can people do. And just to let everyone who's viewing this webinar today know that if you care about the Affordable Care Act and you want to see it fully implemented in the state of Ohio, there are things you can do. You can share this information with your friends and family. You can schedule a presenter to attend a club or an organizational meeting of some group that you belong to. You can either write or learn how, if you haven't done it before, how to write a letter to the editor. Remember, our legislators read those letters to the editor, so it's important. You can attend a Meet Your Legislator event. And in fact, we will have our major event next April, but there are other events that Ohio Consumers for Health Coverage does set up with legislators in between those times. You can stay informed by following UHCAN Ohio and Ohio Consumers for Health Coverage on Facebook and on Twitter, and you can go onto our website and sign up to receive our emailings. So I'm going to hand it back to you, Alyssa.
Okay, if you could just progress to the next slide.
Mm-hmm.
Here's our information. For more information, follow us on Facebook and Twitter. If you need to contact us, call our helpline if you have any healthcare questions. If you need to schedule a presenter, please contact us in the lower right-hand corner. We will post a link to this presentation in our follow-up email, which you should be receiving in the next couple of days, as well as posting this recording up on our website. If you have any questions, please contact any of us here at UHCAN Ohio. Thank you so much for attending this webinar. We hope it was helpful. Feel free to disconnect at this time, and have a great day.